I tell patients that they have a lymphoma, which is a cancer of a cell called the lymphocyte. There are different kinds of lymphocytes, and they have a cancer of the T lymphocytes. Normally, T lymphocytes move around the body, and they like to patrol the skin. The lymphoma occurs when a T lymphocyte mutates and makes many copies of itself. These so-called clones remember that they like to go to the skin, so mycosis fungoides primarily presents in the skin in the form of plaques and patches. If mycosis fungoides progresses, it is likely to spread within the skin and may also spread to the blood and other compartments. Sézary syndrome is a slightly different disease because there are a lot of cancerous T lymphocytes in the blood, so many that you can detect them by testing the blood. Usually, most of the skin has a red cast to it. Unlike in mycosis fungoides, where there are skin areas that are abnormal with normal skin in between. If someone has early stage mycosis fungoides, I tell them that medical literature shows that the majority of patients who are treated with medication will have a normal lifespan. For a patient with later stage mycosis fungoides or Sézary syndrome, I communicate that there are a lot of treatment options. The goal of their treatment is to control progression and manage symptoms, especially their skin symptoms. I emphasize that in the past, blood involvement was associated with a poor prognosis because the degree of blood involvement is basically a measurement of the amount of disease. But the prognosis was poor primarily because we didn't have any good treatments to address it. These days, we have treatments that address blood involvement effectively. So now I tell patients that we can incorporate a treatment to address blood involvement early on. I explain to patients that we take a very different approach to staging blood or liquid tumors than with solid tumors. When patients hear stage 4 cancer, they're thinking about friends or family who have had metastatic breast or prostate cancer. I explain that blood or liquid tumors can go anywhere, so a stage 4 diagnosis doesn't have the same impact with blood cancers that it has with solid tumors. We have very effective systemic treatments, meaning treatments that work throughout the body that can treat the cancer everywhere. I also explain to patients that their disease may progress, but that doesn't necessarily mean that their cancer stage will change. The mycosis fungoides and Sézary syndrome stages were designed to separate patients by prognosis, and they focus mostly on what the skin looks like. Unlike solid tumor progression, during which a patient can progress from stage 1 to 2 to 3 to 4, this is not really the case for mycosis fungoides. So I emphasize that focusing on the stage is probably not helpful to patients. If a patient with patch plaque disease requires systemic therapy, it's probably because they've exhausted other skin-directed therapies. I explain that there aren't any skin-directed therapies left, so we need to try other options. For patients with multiple affected disease compartments, I'll explain that I need to treat them with something that can reach the compartments where they have disease. For a patient with blood involvement, I tell them that if I just shine a light on your skin, the treatment is not getting into your blood. Similarly, for patients with multiple tumors, I explain that I can't irradiate all of them. We have to use something that reaches the tumors via the blood supply. There may be multiple systemic choices that are appropriate for a patient, so I will write them all down, and we go through how they're administered and what the potential side effects are. This way, the patient can be part of the treatment decision. For patients with few options left, I might go through the same exercise, but with the intention of demonstrating why we don't have a lot of choices. For whatever therapy I'm prescribing to a patient, I discuss in great detail the mechanism of action, and I contrast that mechanism to how traditional chemotherapy works. I explain that the therapy I prescribe might target something very specific, while chemotherapy targets any cells that grow quickly, such as cancer cells, or could also affect other cells, such as those inside your mouth or that make your hair grow. While we don't use a lot of traditional chemotherapy for mycosis fungoides or Sézary syndrome, how we characterize these infusions still matters. And it's important that all of your staff is on board with the term infusion. When your nurse refers to any infused treatment as chemotherapy, or your receptionist tells a patient that their chemo is at 11, it can undo the work you've put in, reassuring the patient that their therapy is different.
Indication: Poteligeo mogamulizumab-kpkc injection for intravenous infusion is indicated for the treatment of adult patients with relapsed or refractory mycosis fungoides, MF, or Sézary syndrome, SS, after at least one prior systemic therapy. Important safety information, warnings and precautions. Dermatologic toxicity. Monitor patients for rash throughout the course of treatment. For patients who experienced dermatologic toxicity in Trial 1, the median time to onset was 15 weeks, with 25% of cases occurring after 31 weeks. Interrupt Poteligeo for moderate or severe rash, grades 2 or 3. Permanently discontinue Poteligeo for life-threatening grade 4 rash, or for any Stevens-Johnson syndrome SJS or toxic epidermal necrolysis. 10. Infusion reactions. Most infusion reactions occur during or shortly after the first infusion. Infusion reactions can also occur with subsequent infusions. Monitor patients closely for signs and symptoms of infusion reactions and interrupt the infusion for any grade reaction and treat promptly. Permanently discontinue Poteligeo for any life-threatening grade 4 infusion reaction. Infections. Monitor patients for signs and symptoms of infection and treat promptly. Autoimmune complications. Interrupt or permanently discontinue Poteligeo as appropriate for suspected immune-mediated adverse reactions. Consider the benefit-risk of Poteligeo in patients with a history of autoimmune disease. Complications of allogeneic HSCT after Poteligeo. Increased risk of transplant complications have been reported in patients who received allogeneic HSCT after Poteligeo. Follow patients closely for early evidence of transplant-related complications. Adverse reactions. The most common adverse reactions reported in greater than or equal to 10% of patients with Poteligeo in the clinical trial were rash, including drug eruption, 35%, infusion reaction, 33%, fatigue, 31%, diarrhea, 28%, drug eruption, 24%, upper respiratory tract infection, 22%, musculoskeletal pain, 22%, skin infection, 19%, pyrexia, 17%, edema, 16%, nausea, 16%, headache, 14%, thrombocytopenia, 14%, constipation, 13%, anemia, 12%, mucositis, 12%, cough, 11%, and hypertension, 10%. You are encouraged to report suspected adverse reactions to Kyowa Kirin Incorporated at 1-844-768-3544 or FDA at 1-800-FDA-1088 or fda.gov/medwatch.